Good evening, everyone. I welcome you all to the Oncology Masterclass Lung Cancer Part 2. I'm sure, like the previous masterclasses in oncology on varied subjects, you would benefit from today's lectures and interaction as well. So we have planned 2 talks today, one which I shall be delivering. The subject is ALK-driven non-small cell lung cancer, and the other talk will be on newer updates in immuno-oncology in stage 4 non-small cell lung cancer. So let's begin with my talk. So let me share the screen. I hope my slides are visible now.
Yes, ma'am.
Okay. So I'll be discussing about recent updates in the therapeutic landscape of ALK-driven non-small cell lung cancer. We know that lung cancer treatment has undergone paradigm shift. Lung cancer is no longer a single disease entity. It's in fact a very heterogeneous disease, and it would no longer suffice to just classify lung cancer into small cell and non-small cell subtypes. Also, it would be insufficient to just say adenocarcinoma or squamous cell carcinoma or other types on histological basis. We have learned that there are various molecular subtypes of lung cancer itself. And ALK-positive disease, in fact, is a distinct subset of non-small cell lung cancer. This occurs in almost 5% of patients with advanced non-small cell lung cancer, and it has some peculiar clinical features, such as that it's usually associated with non-squamous histology under the microscope. It commonly is seen in never smokers or former smokers. The patients are significantly younger. Females are predominantly affected, and there usually is an absence of other molecular mutations such as EGFR or KRAS mutations. However, one should not just predict the presence of ALK mutation based on the clinical characteristics, and it's very important, therefore, to test for it in the right way. So this subset of patients is characterized by a rearrangement of the ALK gene. There is rearrangement resulting in a structural alteration of the chromosome, and this change was identified as early as 2007. This identification in lung cancer was soon followed by development of various ALK inhibitors, about which I shall be talking today. Interestingly, the incidence of ALK-positive non-small cell lung cancer is relatively uniform across ethnicity. In USA, it's reported to the tune of 8%, in Europe to the tune of 3.7%, and in East Asia to the tune of 3.4% of all non-small cell lung cancers or of adenocarcinomas. In India, the incidence of ALK-positive NSCLC has been reported variably, possibly due to the different methods of testing used. So it has been reported in various studies to vary from 2.7% to as high as 13%. So as I said, ever since the ALK rearrangement was identified in 2007 in non-small cell lung cancer, various efforts were made to develop the ALK inhibitors. And first one in this race was crizotinib. The landmark study which got the approval for crizotinib was the PROFILE study. And subsequently, there have been various other, so this was the first generation ALK inhibitor. Subsequently, we have had various second generation ALK inhibitors, most notably being alectinib. So let me name all the ALK inhibitors to you: crizotinib, ceritinib, alectinib, brigatinib, and most recently, lorlatinib. In addition, there's one ensatinib, which is not listed here. That's also another second generation ALK inhibitor. So Profile 1014 was a randomized multi-center phase 3 open label study, which compared first-line crizotinib with the standard chemotherapy for ALK-positive non-small cell lung cancer. And this established the superiority of crizotinib when compared to chemotherapy for treatment of this subset of patients. The PFS was impressive. Note the impressive hazard ratio of 0.45. with the use of crizotinib. The overall survival was also impressive. 4-year OS rate with crizotinib was 56% compared to 49% with chemotherapy. And the median OS, in fact, was not yet reached at the point of reporting of that study. However, there's one big limitation with crizotinib, that there is active transport of crizotinib out of the brain by P-glycoprotein, and therefore CNS penetration is limited, further marked by its exit from the brain. And therefore, brain metastases are a very common problem, even in those who have been treated with crizotinib. In addition, it can lead to various resistance mechanisms activation, and therefore, the patient stops responding to crizotinib. So subsequently, there was a need to identify better agents, and then came the second generation agents of ALK inhibition. One of them is ceritinib. This also had a problem of exit from the CNS, and therefore CNS continued to remain a sanctuary site for the tumor growth. However, it is notable that in the ASCENT-4 trial, in patients with brain metastasis and even in those without it, ceritinib did better compared to the comparator. So it has some efficacy, but even that is not enough. And there was therefore continued need to look for better agents in terms of CNS efficacy. In the ASCENT-4 trial, it was found that ceritinib did show significant improvement in the progression-free survival and numerically improved the overall survival. And this was seen, the benefit was seen whether the patient has brain mets or no brain mets. And the GI side effects reported with ceritinib were also manageable, and the efficacy was also demonstrated in Asian patients as well. Then came alectinib, which is a very potent inhibitor of ALK. It is very potent, and it also targets the various resistant mutations which are responsible for loss of efficacy to crizotinib as well as ceritinib. So this is much more potent, is much more broader in terms of coverage of varied types of mutations. It also, in addition, achieves a high CNS penetration and therefore has much better intracranial efficacy. Now, alectinib also is characterized by the largest body of evidence, academic evidence, based on all these 4 trials that I have listed here. One of them is a phase 2 study, the AF001JP study in Japanese patients, and all other are phase 3 studies, namely JLX, LX, and Alicia. So all these studies have in fact reported consistent good results with the use of alectinib for first-line treatment of ALK-positive non-small cell lung cancer. Now, LX study had included advanced non-small cell lung cancer harboring ALK gene rearrangement as per the IHC test. The patients had to be treatment naive and in good performance status. The patients were randomized 1:1 to receive alectinib in the standard dose of 600 milligrams twice a day, or crizotinib in the again standard dose of 250 milligrams twice a day. Patients were stratified as per the CNS metastasis presence or absence. Also, stratification was done based on whether they were Asians or non-Asians and what was the performance status. The patients were followed until disease progression or unacceptable toxicity. Now, the updated results of LX trial have reported a marked significant improvement in the median progression-free survival. It was 34.8 months with alectinib versus only 11 months with the crizotinib. The hazard ratio was 0.43. So patients were progression-free for almost 3 years with alectinib. Now, in the intention to treat analysis, if you notice here at end of 4 years, 43.7% of the patients were alive, event-free, when they were treated with alectinib, compared to almost none when they received crizotinib. So quite impressive results there in terms of progression-free survival. What about the CNS penetration and CNS response? So alectinib was found to reduce the risk of CNS progression quite significantly. In fact, at 12 months, only 9% of the patients had a CNS event compared to 41% with crizotinib, resulting in 84% reduction when compared with crizotinib. The overall response rate. So we often look and get impressed with the overall response rates, but the duration of response is also very, very important and sometimes much more important. So if you notice here, there wasn't much difference in terms of overall response rates. Crizotinib led to a response rate of 75% versus 83% with alectinib. But you would notice here that the duration of response was almost triple with alectinib to the tune of 33 months compared to only 11 months with crizotinib. So it's quite durable. The response is achieved in very many more patients, and it's durable as well. What about the overall survival data? With alectinib, look at the hazard ratio. There was 33% reduction in the risk of death when the patients received alectinib. 6 out of 10 patients were alive at 5 years. So again, it's outscoring crizotinib. What about the safety profile? In this ALEX trial, even though the median treatment duration with alectinib was 28 months versus only 10 months, so almost 3 times when compared to crizotinib, the rates of dose reductions, interruptions, and discontinuations were quite similar between the two arms. And therefore, it can be concluded that alectinib is well tolerated even over long-term use. So alectinib became the preferred first-line treatment option and the standard of care for treatment of patients with ALK-positive non-small cell lung cancer because of its significant improvement in the progression-free survival seen till date to the tune of 35 months. Also, its efficacy in terms of prevention and treatment of CNS metastasis. Also, because of meaningful improvement in the overall survival when compared with crizotinib, and also because it was found to be well tolerated with manageable safety profile. Then came brigatinib. So ALTA-1L is the trial which studied in phase 3 manner the efficacy of brigatinib versus crizotinib. And this was again the patients, advanced lung cancer patients, ALK positive in good performance status with no symptomatic CNS metastasis were randomized to receive brigatinib or crizotinib. Brigatinib was given in the dose of 90 milligrams once a day for 7 days and then escalated to 180 milligrams to be continued once daily. And in this, it was found to be efficacious. The overall response rates to the tune of 53%, median duration of response being 13.8 months, and quite significantly high intracranial overall response rates as well to the tune of 67% seen with brigatinib. So this is the comparative curve. Brigatinib, this is how the curve looks, the top one, when compared to crizotinib in terms of progression-free survival. And this is what is seen as its efficacy in terms of intracranial control rate. We then have third generation ALK inhibitor, lorlatinib. Now, the efficacy of lorlatinib was first reported in phase 1 trials, and this was found to work not only in ALK positive, but also in ROS1 mutated non-small cell lung cancer patients, found to be efficacious even when the prior TKIs had failed based on the phase 2 data. Lorlatinib was used in the dose of 100 milligrams once daily until progression. And it seemed to result in very meaningful and significantly high overall and intracranial tumor responses. It was also found to be effective in ALK resistance mutations, especially the typical resistant one being G122R, wherein lorlatinib is the only one which was found to be effective. So then came this trial, the phase 3 trial, the CROWN study, which compared lorlatinib with crizotinib in the first-line treatment of patients with advanced ALK-positive non-small cell lung cancer. So again, patients with advanced cancer, good performance status, the patients with asymptomatic treated or untreated CNS mets were permitted randomization 1:1 to receive lorlatinib 100 milligrams a day with crizotinib 250 milligrams twice a day. Look at the PFS. The hazard ratio was 0.28. This you would notice as the lowest figure of hazard ratio that I have spoken about since the beginning of my talk today. The median PFS not yet reached compared to 9.3 months with crizotinib. Quite good and wide separation of the PFS curves. Even when PFS was reported by the investigator, hazard ratio 0.21. So marked improvement in the progression-free survival. And on subgroup analysis, all the subgroups seem to benefit, whether they had brain mets or not, whether they were Asians or not Asians, irrespective of the gender or age, less than 65 or more than 65, irrespective of the smoking status, they all did better with lorlatinib when compared to crizotinib. Response rate 76% versus 58% with crizotinib. Median duration of response not yet reported versus 11 months with crizotinib. So some CRs and partial response also reported, and much better when compared to crizotinib. What about the intracranial response? 66% intracranial response in those with measurable or non-measurable brain mets at baseline, and patients with measurable brain mets has as high intracranial response rate as 82% with lorlatinib versus only 23% with crizotinib. And intracranial complete response rate, note here, 61% in the overall group and 71% complete response rate in the brain mets in those with measurable brain metastasis. So quite stark difference there. And this is how the curves look in terms of intracranial time to progression with lorlatinib. Hazard ratio of 0.07. So almost nobody would have an intracranial progression when given lorlatinib. And if develops or if has, then would do very well. The overall survival median is not yet reached at the time of reporting of this study. Two peculiar side effects with lorlatinib: hypercholesterolemia and hypertriglyceridemia, which are not seen with crizotinib. They are peculiar, however, they are manageable if one is aware. So in CROWN 3 trial, CROWN study, a phase 3 study, lorlatinib was found to result in significantly longer PFS, significantly higher overall and intracranial response rate, and improved global quality of life. Intracranial response rate of 82% with a CR rate of 71% is quite stellar. Even though grade 3-4 side effects were more frequent with lorlatinib, however, majority were lab abnormalities rather than symptomatic adverse events. So this trial, CROWN study, brought lorlatinib as effective first-line treatment in ALK positive. So to sum up, this is the table that I would want you to focus your attention on. So I have tried to list here all the 4 important newer molecules, namely lorlatinib, alectinib, brigatinib, and ensartinib. The trials, namely CROWN study, the LX that I talked about, ELTA-1L that I also talked about, ensartinib, the trial is EXALT-3, and the impressive CNS control rates that I reported with both lorlatinib and alectinib as reported in these studies, impressive PFS, intracranial response rates, including complete intracranial response rates with lorlatinib. So these are different types of molecules that we are using to treat our patients. The safety and toxicity profile, one needs to be aware and therefore monitor. So as I said, lorlatinib, peculiar lab abnormalities, hypercholesterolemia, hypertriglyceridemia leading to weight gain, some peripheral neuropathy. Alectinib is characterized by anemia, myalgias. We even need to monitor CPK levels in the serum, can lead to musculoskeletal pain and also increase in weight. LFTs need to be monitored. Brigatinib is characterized by peculiar interstitial lung disease. Ensartinib, though not available to us, but is known to cause skin toxicity in form of rash and pruritus. So we have come a long way in terms of treatment of lung cancer and ALK positive non-small cell lung cancer, which many patients we earlier used to lose because of CNS disease are now getting saved for longer and longer with the use of drugs like alectinib and lorlatinib. So I would end here, and I would now request my colleague, Dr. Nagendra Sharma, to deliver his talk, and he'll be talking about newer updates in immuno-oncology in stage 4 non-small cell lung cancer. So welcome, Dr. Nagendra.
Thank you. Thank you very much, ma'am, for exciting discussion. So much new things we have learned from the last presentation which you have made. I think my slides are visible.
Yes, sir. Perfect.
Right. So moving to the second topic, that is newer updates in immuno-oncology as far as the stage 4 NSCLC is concerned. Right. So where are we in 2022 as far as immuno-oncology drugs are there in stage 4 NSCLC? So I will be covering this topic, and before that, at the outset, I want to thank Dr. Vaidya for giving me the opportunity to be a part of this scientific quiz. So this is a hospital where we work, and the burden of lung cancer in India, the global data have shown that the lung cancer is the second most common cause of cancer in male, right? So nearly 8% of the 2022 all male or all ages were lung cancer. And if you see the number of new cases in 2022, both sexes, all age, it is around 5.5%. So it is a both incidence and mortality, if you see, and prevalence by cancer side. So lung cancer is 5.5% as far as new cases are concerned. As far as death is concerned, 7.8% of the patients will die, and 5-year prevalence, that is the proportion of patients per 1 lakh population, is 5.86. So majority, 75% of the patients with NSCLC are diagnosed in late stages. Globally, lung cancer is divided into 4 stages, and only up to stage 1, 2, and partially stage up to stage 3 or 3B will be resectable. That is, only 25% of the NSCLC are eligible for surgery. 75%, that means 3/4 of the lung cancer patients in NSCLC subset are unresectable upfront. So I want to tell here that there is a difference between operability and resectability. So operability depends upon cardiopulmonary function and the performance status of the patient. But resectability depends on the anatomical staging, depending on the site and size of the disease. So cancer which is operable may not be resectable, and the cancer of lung which is resectable may not be operable. So in lung cancer, 75% of the patients are diagnosed in advanced stages, and 75% of the patients have unresectable disease. So if you see in India, fewer patients are diagnosed in the earlier stage. In India, if you see, stage 1 and stage 2 comprise only 3.5% of the population of the lung cancer, and stage 3A is 13.1, stage 3B is 30.1, and stage 4 makes the major chunk, that is 53.3%. That is the focus of presentation today. So staging of lung cancer, we all know it is divided. We are using TNM staging, and the metastatic stage is stage 4A and stage 4B. As far as A stage is the IASLC or UICC classification is concerned. So M1A, when there is a decimated involvement of malignant pleural effusion or pericardial effusion or pleural pericardial nodules, M1A is condylated nodules are positive, and M1B is when single extrathoracic metastases are there, M1C when there are multiple extrathoracic metastases. So stage 4 NSCLC, we all know that the most common sites of advanced disease or metastatic sites are brain, bone, liver, adrenal, and kidney. With no cure, the treatment of stage 4 NSCLC is focused on improving the survival and often incorporate systemic and targeted therapies. The stage 4 NSCLC is defined by presence of distant metastasis. Treatment is aimed at increasing overall survival, although quality of life is an important factor in this patient, and treatment strategies should take into account factors such as histology, molecular pathology, biomarkers, age, performance status, comorbidities, and patient preference. The main histological subtype of stage 4 NSCLC is squamous cell carcinoma and NSCLC, we all know, and which includes adenocarcinoma. And patients with widespread and metastatic disease are usually candidates for systemic treatment, including chemotherapy, targeted therapy, immunotherapy, clinical trials, and palliative care. The targeted measures are recommended for specific types of metastasis. So, over a period of time, in the last 2 decades, we have seen that there is an evolution of therapy. There is a paradigm shift as far as lung cancer treatment is concerned. So, NSCLC was once considered as a single disease until distinct subtypes or characteristics were identified. NSCLC subtypes characteristics are clinically relevant for treatment planning and diagnosis. So initially, only 2 classifications were there, like NSCLC and small cell lung cancer. Then it histologically was broken into squamous, non-squamous, large cell, adeno. Then molecular pathology came into existence, and EGFR, ALK, ROS1, PD-L1, and over a period of time we came to know BRAF, MET, RET, NTRK, HER2, KRAS. There are so many molecular subtypes of NSCLCs. Then came the PD-L1 expression. In that also we have got less than 1%, 1% to 49%, greater than equal to 50%. So, and tumor mutation burden also came into existence recently, in which whether the mutations are less than 10 mutations per megabase or they are greater than equal to 10 mutations per megabase. So there is a definite role of immunotherapy. It has changed as far as management of NSCLC is concerned. 2018 Nobel Prize was given for the discovery of immunotherapy in lung cancer. T. Honjo and James P. Ellison were the Nobel laureates who got these Nobel Prizes. So chemotherapy, we know that it induces a tumor cell killing, which may induce a tumor antigen release and exposure to immune cells, and PD-L1 expression leads to immune cell invasion and T cell invasion. PD-L1 or PD-L1 inhibition restores the tumor-specific T cell immunity, and there is a reversible immune suppression leads to deeper, more durable systemic anti-tumor response. This is the way by and large it works. So now coming specifically to the topic, so what are the current paradigm shifts for immunotherapy in advanced NSCLC who are having no targetable actionable mutation? So in that, basically we look into PD-L1 percentage. We are having various platforms. We are having DACO22C3, we are having SP263, SP142. So PD-L1, if it is 1 to 49% or if it is less than 1%, the standard of care will be immuno-oncology drugs, immune checkpoint inhibitors, and chemotherapy plus chemotherapy. For those patients who are having a PD-L1 percentage of greater than 50%, the choice of single-agent immuno-oncology drugs like immune checkpoint inhibitors or immune checkpoint inhibitors plus chemotherapy can be considered. Those patients who are having high volume of disease or high mutation or high tumor burden of the disease. Single-agent immune checkpoint inhibitors are approved for PD-L1 greater than equal to 1%, but not broadly recommended by experts. So for those patients who are having PD-L1 low, that is less than 1% or 1 to 49%, if they are having squamous histology, we can go for chemotherapy plus PD-L1 inhibitor. And for those patients who are not having any squamous histology, that means non-squamous histology, we can go for chemotherapy plus PD-L1 inhibitors. And PD-L1 high greater than equal to 50%, will use PD-L1 inhibitor alone or chemotherapy plus PD-L1 inhibitor. So in May 2020, nivolumab, that is IO drug combination, got approved for the first-line treatment of advanced NSCLC who are having a PD-L1 greater than equal to 1%, and NeoIP plus 2 cycles of platinum doublet chemotherapy approved for first-line treatment of advanced NSCLC without EGFR and ALK genomic aberration. So TMB also, the tumor mutation burden and tumor PD-L1 expression identified invented an independent publication of NSCLC. So by which we'll come to know that like the Checkmate 227, the famous Checkmate 227 trial has taken into consideration TMB and PD-L1 expression both. So all TMB evaluable patients were taken into consideration, and the NeoIP and chemotherapy arms, those 29% of patients were having PD-L1 less than 1%, and those patients who are having PD-L1 greater than equal to 1% was 71%, and in those patients, the tumor mutation burden was greater than 10 mutations per megabase. For those patients who are having tumor mutation but less than mutation per megabase were 31%, and PD-L1 less than 1% to 9%. So post first-line advanced NSCLC immunotherapy trials, an ever-going list is there. So we are having a lot of plethora of options right now. So we are having a famous landmark Keynote 189 trial in which pembrolizumab used plus placebo which was compared with the platinum doublet with placebo. It was for PD-L1 unresected and non-squamous histology. It has got a very beautiful objective response rate. It's 48.3%, vis-a-vis 19.9%, and PFS hazard ratio was 0.49, favoring the pembrolizumab arm, and overall survival hazard ratio was 0.56. Then came Empower 113, which atezolizumab plus nab-paclitaxel was used. Empower 115, which atezolizumab plus carbo-pacli was used, and was plus bevacizumab also was added to that. We call it ABCP regimen, which was compared with bevacizumab plus chemotherapy. Then came the Checkmate 9LA trial, which NeoIP plus chemotherapy backbone of platinum doublet was used and was compared with platinum doublet chemotherapy, and it was for PD-L1 unselected population. It has got a very good objective response rate. Then came Keynote 407 trial for squamous histology, Keynote 042 trial for pembrolizumab versus platinum doublet chemotherapy, in which PD-L1 is greater than 1%. Checkmate 227 NeoIP trial, in which TMB high or low and along with PD-L1 were taken into consideration. Empower Lung 1, Keynote 024, and Empower 110 trials are there, in which cemiplimab, pembrolizumab, was used. So there are so many options in which many of them are positive, and How do we choose now? This is the question which is standing unanswered. So, which one to pick up? FDA-approved analysis of first-line chemotherapy IO versus IO therapy in advanced NSCLC, PD-L1 percentage. So these are the trials in which they have used. IO alone was Keynote 042 and Checkmate 227, and chemo IO was Keynote 189, Keynote 407, Keynote 021, Cohort G, Empower 150, Empower 130 Arizona trials, and Checkmate 9LA. So data pulled from 8 randomized controlled trials evaluating the anti-PD-1 and PD-L1 therapy alone or in combination with chemotherapy for first-line treatment of advanced NSCLC, PD-L1 expression with EPS, that is tumor staying the patterns, and the tumor infiltrating immune cells were excluded. And this was the key endpoints of this trial were overall survival and PFS. So in advanced NSCLC with the PD-L1 1 to 49%. So this was a trial in which chemotherapy IO was compared with IO alone, and it has shown that median was 21.4 months as compared to 14.5 months. Hazard ratio was 0.68, favoring the experimental arm. Advanced NSCLC, those patients who are having the PD-L1 percentage of 1 to 49% as per the PFS analysis, chemo IO versus IO alone, it has shown that median PFS also was favoring chemo IO arm, that is 10.7%, 10.7 months, and hazard ratio 0.64. As you can see, the Kaplan-Meier curve are wide apart. Checkmate 227. This is a first-line combination IO drugs in which CTLA-4 inhibitor ipilimumab was combined with PD-1 antagonist nivolumab, which was compared with chemotherapy for advanced NSCLC. And this trial was very, very important because up to 2 years chemotherapy was used, and it was in Part A and Part B. The patient with stage 4 or recurrent NSCLC without non-sensitizing EGFR alteration, no previous systemic treatment, with good performance status, who are untreated CNS mets were taken into consideration, and more than 1,700 odd patients were taken into consideration. So it was Part 1A was PD-L1 greater than equal to 1%, and Part 1B was PD-L1 less than 1%. So Nivo-IP in the dose of 3 mg per kg over 2 weekly nivolumab and ipilimumab 1 mg per kg over 2 6 weekly was used, and another arm nivolumab are also used in the same dosages, and the dual primary endpoint of Nivo-IP arm was PFS in those patients who are on high tumor mutation burden, and overall survival in PD-L1 greater than equal to 1% population. And post-hoc analysis of the efficacy of the patients who discontinued was also checked. So as you see, the overall benefit, overall survival was favoring Nivo-IP arm. That is 17.2 months median overall survival as compared to 15.2 months with Nivo chemotherapy, and chemotherapy was only 12.2 months. So hazard ratio was 0.64, favoring Nivo-IP. In non-squamous histology and squamous EPC, non-squamous also, it was more or less 17.5 months median overall survival, and Nivo-IP plus chemo also, it was 7.7 months, so it was not favoring Nivo-IP. In squamous histology, it was favoring Nivo-IP 15.9 months median overall survival, and hazard ratio was 0.53, favoring Nivo-IP arm. Checkmate 024, this first-line pembrolizumab for advanced NSCLC. It was an open-label randomized phase 3 study in which pembrolizumab 200 mg IV Q3 weekly up to 35 cycles was compared with platinum doublet for 4 to 6 cycles, and primary endpoint of this trial was PFS by blinded independent central review, and secondary endpoint was objective response rate, overall survival, and safety. The immunotherapy drug was continued until progressive disease or unacceptable toxicity, and crossover to pembrolizumab was allowed in the competitor arm. So both squamous and non-squamous histology were taken into consideration in this trial, and they were certified based on the histology, eco performance status, and enrollment regimen. So as you can see, the Keynote 024 trial, the PFS advantage was favoring pembrolizumab, that was 10.3 months, and the 6 months and 12 months PFS also was much, much better. And overall survival also was favoring pembrolizumab. The median also was 30 months, and 12 months and 24 months were also much, much better. As you can see, preliminary curves are wide apart, and hazard ratios are favorable. Keynote 042 trial was there for those patients who are in the first-line pembrolizumab. It was compared with chemotherapy for advanced NSCLC with PD-L1 TPS greater than equal to 1%. So in this, primary endpoint was PFS by blinded independent central review, and secondary endpoint was objective response rate, overall survival, and safety, and treatment was continued till progression on acceptable toxicity, and no crossover to pembrolizumab was allowed in the competitor chemotherapy arm. The Keynote 042 trial, the positive, which is the positive trial for those patients who are having a PD-L1 of greater than equal to 1%, but the benefit primarily given by the patient PD-L1 greater than equal to 50%. As you can see, those patients who are having PD-L1 TPS score of greater than equal to 50%, the hazard ratio is 0.69, and for those patients who are having a PD-L1 greater than equal to 1%, hazard ratio was 0.81. And PD-L1 TPS greater than equal to 20%, it was 0.77. So PD-L1 greater than equal to 50% is where the magic is, isn't it? So higher the PD-L1 percentage, more likely the patient is going to get benefit from oncology drugs, especially pembrolizumab, right? So lesser the hazard ratio, better is the experimental arm. So in the patients who are having PD-L1 TPS greater than equal to 50%, the hazard ratio was 0.69, favoring pembrolizumab. So keynote 042, should pembrolizumab monotherapy be the treatment of choice for PD-L1? Monotherapy should be excluded for those patients who are having PD-L1 between 1 to 49%. So this excluded, this has no benefit of pembrolizumab versus chemotherapy in PD-L1 TPS 1 to 49% subgroup. It's not correct to say that pembrolizumab was just as good as chemotherapy with less toxicity. Pembrolizumab had equivalent survival to standard control arm, no crossover to immunotherapy was permitted. Although FDA approved in this setting, pembrolizumab is an superior choice for patients with low PD-L1 expression. Immunotherapy is much better choice in this population. Then came the keynote 189 trial, the first line pembrolizumab plus chemotherapy arm plus placebo, which was compared with placebo plus chemotherapy in stage 4 non-squamous NSCLC. So it was a randomized double-blind international phase 3 study in which patients were stratified based on PD-L1 score, platinum doublet, whether it's cisplatin or carboplatin, or smoking history. So no actionable EGFR augmentation and no symptomatic CNS brains were allowed, and pneumonitis requiring treatment also was excluded, right? So primary endpoint of this trial was overall survival, PFS by random independent sample review, and key secondary endpoints were objective response rate, duration of response, and safety. So in this 4 cycles of pembrolizumab plus platinum doublet was used, and it was compared with placebo and platinum doublet. It is 2:1 randomization, and if there is no progression, this was continued. That pembrolizumab plus pembrolizumab was continued till progression or unacceptable toxicity. If there is no progression, then placebo plus pembrolizumab was used up to 35 cycles. So keynote 189 trial, overall survival you see intention to treat population, the hazard ratio for death was 0.49. Kaplan-Meier curves are wide apart. For those patients who are having a PD-L1 less than 1%, the hazard ratio was 0.59. For those patients who are having a PD-L1 1 to 49, it was 0.55. And for those patients who are having PD-L1 greater than equal to 50%, it was 0.42. So this was favoring the experimental arm. Then comes the Atezolizumab trials, that is Empower 150 trial, in which atezolizumab was combined with platinum, taxane, and bevacizumab. That is ABCP regimen, we call it. And this was compared, it was 3-arm trial in which this 3 combination was used, along with that bevacizumab was used in second arm, and only platinum doublet with bevacizumab was used without atezolizumab in the third arm. So all those patients who are in stage 4 or recurrent chemotherapy naive non-squamous NSCLC were taken into consideration, and maintenance therapy was allowed. No crossover was permitted, and those patients who have got a good response or partial response, they were continued for atezolizumab monotherapy in the arm first, and arm 2 it was atezolizumab bevacizumab was continued, and for arm 3 only bevacizumab was used as a maintenance. And atezolizumab was used until progression or unacceptable toxicity. The primary endpoint of this trial was PFS, OS, and secondary endpoint was PFS, objective response rate, and overall survival. So Empower 150 trial also had shown that the PFS and overall survival also was favoring the ABCP arm. As you can see clearly, the Kaplan-Meier curves are wide apart. It was PFS was 8.3 months and hazard ratio 0.59. And those patients, overall survival in international treat population also, it was median overall survival 9.8 months and 0.76 favoring the ABCP arm. Empower 130, in which nab-paclitaxel, that is steroid-free regimen, was used along with plus minus atezolizumab in advanced NSCLC for non-squamous histology. It was also a randomized multi-center open-label phase 3 study, and the primary endpoint was PFS, the secondary endpoint was PFS and overall survival in infection-free population by PD-L1 expression. So this nab-paclitaxel, atezolizumab, and carboplatin was used for 4 cycles. Then atezolizumab was continued as a maintenance therapy till progression. And in the competitor arm, that is nab-paclitaxel carbo, parameter said maintenance was used, and then if progression, then atezolizumab was used until progression. The crossover was allowed until 6th of June 2016. So Empower 130 trial also is favoring the atezo plus chemotherapy arm. That the median PFS was 7 months, hazard ratio 0.64, median overall survival 18.6 months, and hazard ratio 0.79 favoring the experimental arm. Keynote 407 for squamous histology of advanced NSCLC, in which carboplatin, paclitaxel, nab-paclitaxel was used And this also was a positive trial. Primary endpoint was PFS, and key secondary endpoint was objective response rate and duration of response. 2 arms, pembrolizumab plus carboplatin, and like the Trexin was nab-paclitaxel or paclitaxel was used for 4 cycles and continued for pembrolizumab if the patient is responding for up to 31 cycles. And those patients who are carboplatin plus nab-paclitaxel was used and continued for placebo 31 cycles, and on progression crossover was allowed and pembrolizumab was used till 35 cycles. So as you can see, in chemocystology, advanced NSCLC, keynote for not several, PFS also was favoring pembrolizumab plus chemotherapy arm in chemocystology, right? In those patients who are having higher PD-L1, the responses are much better as compared to those patients who are having lesser PD-L1. So hazard ratio less than PD-L1 was 0.68, 0.56 for 1 to 49, and 0.37 for greater than equal to 50% of PD-L1. Keynote 407 oral survival also was favoring pembrolizumab plus chemotherapy arm. The median oral survival was 15.9 months, and it was favoring those patients who are having higher PD-L1. Checkmate 9 trial, NeoEP trial, in which it is also phase 3 trial, in which NeoEP was used at the dose of 300 mg and 1 mg per kg body weight, respectively, along with chemotherapy. 2 cycles were used, and chemotherapy was used for 4 cycles in the competitor arm. Primary endpoint was overall survival, and key secondary endpoint was PFS, objective response rate, and efficacy by tumor PD-L1 expression. As you can see, in the overall survival, NeoEP plus chemotherapy have shown an overall survival of 15.6 months. This is the median overall survival, and hazard ratio 0.66, favoring NeoEP and chemotherapy arm. As you can see, the Kaplan curves are wide apart, and the overall survival benefit was there at 6 months, 12 months, and beyond. And the plateau, and it is like responses are much more durable. CCTGBR.34 trial, durvalumab plus minus chemotherapy was used in stage 4 NSCLC. It was also randomized open-label phase 2 study in which stage 4A and 4B, histology and smoking status were the strategic factors. And durvalumab was used at 1.5 gram, that is 1,500 milligram IV plus simulumab 95 milligram IV Q4 weekly cycle, and this was compared with durvalumab with chemotherapy doublet, and durvalumab was continued as a maintenance therapy, and in the experimental arm, and the competitive arm it is durva plus pembrolizumab and key progression. The primary endpoint was overall survival. This is a phase 2 study. Primary endpoint was overall survival, and it has shown that primary overall survival was better with those patients who have been exposed to durvalumab and chemotherapy. It is 16.6 months versus 14.1 months in median overall survival. Hazard ratio 0.88. Although it is a phase 2 trial, it has to be checked in phase 3 before it comes to the practice. Mystic trial, in which overall survival across PMB cutoffs with durvalumab and durvalumab versus chemotherapy was used. As you can see, the higher the PMB, that is greater than equal to 20, the responses are much better, which favors durvalumab and durvalumab. So greater than equal to 20 mutations per megabase cutoff selected based on observed effect size of durvalumab and patient population with benefit. So low PMB, it is not favorable. This was a Mystic trial of durvalumab. So overview of chemotherapy as a second line of subsequent therapy to advanced NSCLC. We have in vivo, we have in pembrolizumab, vedolizumab, avelumab, and durvalumab. There are plethora of options in second line and progression disease also. So there are Checkmate 017057 OAK trials and Keynote 010 trials, in which overall survival benefit was observed across PD-L1 spectrum, including less than 1% PD-L1 expression and a half benefit with increasing PD-L1 expression were taken into consideration. Approved for 3 PD-L1 inhibitors in rapid succeeded advanced NSCLC. So Nevo FDA approval got in 2015, Nevo FDA approval, pembrolizumab approved in 2015, and edizolizumab got FDA approval in 2016. So Checkmate 017 trial for squamous, Checkmate 057 for non-squamous. This was compared with docetaxel in previously treated advanced NSCLC, and this is also a wonderful trial, and the responses are much more durable. Checkmate 017 and 057 oral survival with minimum follow-up was published, and it has shown that it has got a overall survival benefit, right? Hazard ratio 0.62, favoring durvalumab over docetaxel, and 057 trial of Checkmate also have shown for non-squamous, also it is favoring durvalumab, right? Keynote 010, pembrolizumab was compared with docetaxel in advanced NSCLC in PD-L1 positive NSCLC, a 3-arm trial in which pembrolizumab was used alone, pembrolizumab different dosage, 2 mg per kg 2-3 weekly and 10 mg per kg 2-3 weekly, compared with docetaxel 75 mg per kg 2-3 weekly. The median over like 5.9 points for overall survival PFS. Key secondary endpoint of the duration response, objective response rate, and safety, and treatment continued up to 24 months and until progressive disease or unacceptable toxicity. So this also is a positive trial, which is favoring that if you use the higher doses of pidolin also, this are even better as far as overall survival is concerned. Keynote 010 trial, subgroup analysis favoring that all, whatever the sex of the patient, male, female, irrespective of age, performance status, pidolin proportion, archival immune tissue was taken, histology or EGFR mutant status or wild type, it is favoring pembrolizumab as far as Keynote 010 trial is concerned. So all dots are on right end of unity favoring pembrolizumab. Hope trial of adizumab versus docetaxel also in progressive disease have also shown that primary endpoint of the trial was overall survival in international treated population, and the key secondary endpoint of this trial objective response rate PFS, in which adizumab 1,200 mg Q3 was compared with docetaxel, and this was no crossover was allowed in metastatic locally advanced NSCLC in second line and third line who are having progressive disease on prior platinum-based treatment. It was continued till progression on acceptable toxicity. Hope trial also was a positive trial in which they have got a landmark 12 months and 18 months overall survival benefit favoring atezolizumab, and the responses are much more durable, and those patients are having greater than PD-L1, the responses are much better. Hazard ratios were favorable. There are resistance to immunotherapy also which can develop. Just a brief touch I will do because of limitation of time. STK11 and LKB1 genomic alteration in non-stem histology. This mediates the cold tumor immune check microenvironment and are major driver of primary resistance to PD-L1 axis blockage. So this also we have to figure it out, and we are in pipeline right now. Other things are I will be touching the future IO options that the resistance to IO. They are in development right now. There are multiple things which are going on right now, but none of them are in phase 3 trials. Unless mature data is there, it is difficult to predict. Primary and secondary resistance to IO is what we are looking for in future. So to conclude, the immunotherapy landscape in advanced NSCLC, higher PD-L1 greater than 50%, pembrolizumab monotherapy considered histology-specific chemoimmunotherapy trial. Drugs, PD-L1 1 to 49 or less than 1%, histology-specific immuno or chemotherapy, pembrolizumab monotherapy is FDA-approved option for 1 to 49, but suboptimal. Several chemoimmunotherapy trials are positive for non-squamous histology and squamous histology. In summary, immunotherapy remains a standard of care for those patients with disease progression on or after platinum-based chemotherapy doublet as first-line treatment. Second-line immunotherapy will become less relevant as more patients receive first-line immunotherapy as single agent or in combination. Pembrolizumab plus minus chemotherapy, atezolizumab plus minus chemotherapy, or nivo-IP. We await outcomes of ongoing trials of treatment after progression on first-line immunotherapy, monotherapies, or in combination. Currently, there is no way to identify patients who will benefit from treatment beyond progression. Early indications suggest prior immunotherapy may alter responses to subsequent therapy, but additional evidence is needed before commenting upon that. Some EGFR ALK positive patients may benefit from immunotherapy plus chemotherapy combination, in contrast to lack of benefit seen in single agent immunotherapy in this population. Randomized studies are needed to explore regimen, timing, and patient characteristics for possible benefit in this patient subset. So, word of wisdom at the end of this presentation, I will say that direction is so much more important than speed. Many of us are going nowhere fast. And if you want to walk fast, walk alone. And if you want to walk far, walk together. Thank you very much for patiently listening.
Thank you, Dr. Nagendra, for that extensive talk on immuno-oncology in lung cancer. Extremely sorry that our organizing chairman and program director for today, Dr. Ved, couldn't join us today due to some personal reason. If there are any questions by any of the students or participants or attendees, we'll be happy to answer. So they could be put in the chat box, or Mr. Nirav, you could bring it up.
Still, we have not received any questions, ma'am. So if you have any discussion or something.
So are there any questions, Mr. Nirav?
Still, we have not received any questions. Still, we have not received any question, ma'am.
Okay. So then do we close, or? I'll sum up then today's talks.
Yes, ma'am.
Okay. So Today, we have discussed about two very important topics. We have talked about a subset of non-small cell lung cancer patients who harbor ALK gene rearrangement. We have become aware that we have 5 ALK inhibitors available for use to us. We have talked about first generation, second generation, and third generation of ALK inhibitors. Just for the information of students, there's fourth generation ALK inhibitor also undergoing active research, because we know that there are some, smaller subsets of ALK mutation positive patients who would still not respond to even a drug like lorlatinib, and therefore need a different approach. There are studies which are looking at the combination of ALK inhibitor with immunotherapy, with chemotherapy, with anti-angiogenesis drugs to improve the efficacy and to make the outlook better for such patients. So the research goes on. One needs to be aware of not only the efficacy, but also the side effect profile of all these agents before prescribing any of these agents to our patients. Coming to immuno-oncology, the area is vast. Immuno-oncology has come a long way, especially in lung cancer, wherein even PD-L1 negative patients are shown to benefit from addition of immunotherapy to chemotherapy. And the role of immunotherapy is being extended to various other subsets of lung cancer. As I just mentioned, even those who harbor these driver mutations, earlier we thought that there was no role of IOs, but there is a definite role of IOs, especially when combined with chemotherapy or other agents. So the research is on, active research is on, and the precision oncology is growing by leaps and bounds. So we would conclude today's masterclass on lung cancer today. Thank you everyone for joining in. Thank you.
Thank you. Thank you.